Hello, everyone. I'm Ms. Han from the Canadian Synergy Conference Organization, and I'm honored to introduce our moderator, Dr. Gulbahtiar, MD from the United States. Before moving forward, on behalf of Mr. Ahmadullah, the CEO of our conference organization, I would like to express our deepest gratitude for accepting to be the moderator in this educational event. Let me give you a brief introduction of Dr. Bhatia. Dr. Gulbahtiar is a clinical professor of medicine at NYU Grossman School of Medicine. She is board certified in endocrinology, diabetes, and metabolism, as well as obesity medicine. She also has certification in plant-based nutrition through eCornell. Dr. Bhatia has been active since 2005 as a clinician, teacher, journal editor, and clinical investigator. She has been published extensively in the field of endocrinology. She was instrumental in establishing the Endocrinology Fellowship Program affiliation with SUNY Downstate Health Science University at H&H Woodhull. Through this fellowship program, Dr. Bhatia mentored numerous endocrinology, diabetes, and metabolism subspecialists. Now I would move the mic towards Dr. Bhatia. Here you go, Doctor.
Thank you very much, Sada, for the kind introduction. And good afternoon, everyone, and thank you for joining to our webinar. Today, our speaker is Dr. Ellen Sacerdote, who is an expert on steroid pathway, non-classical adrenal hyperplasia, PCOS, and insulin resistance. Dr. Sacerdote is a clinical professor of medicine at NYU Grossman School of Medicine and State University of New York Health and Science Center. He was the division chief of endocrinology at the Health and Hospital Woodhull Medical Center in Brooklyn, New York, and recently retired after 35 years of service. Beside being an excellent clinician, mentor to endocrine fellows, medical residents, and students, Dr. Sacerdote has numerous publications and contributed significantly to the field of endocrinology. Today, he will share his expertise with us, and without further ado, I turn the microphone to Dr. Sacerdote.
Thank you, Dr. Bhatia, for your very kind introduction. And I would also like to thank Synergy Conferences, Mr. Ahmadullah and Sadaf Khan for organizing this webinar. The title of our webinar today is Autoimmunity, Insulin Resistance, Congenital Adrenal Hyperplasia, Vitamin D, and the Biome. So for those of you who thought you were attending the World Economic Forum, you might be in the wrong place. Everybody else, welcome. Our first statement might be a little surprising to many people, but patients with autoimmune disorders generally have non-classic adrenal hyperplasia. And the disorders that our group has investigated in this regard include people with type 1 diabetes, people with Graves' disease, people with Hashimoto's thyroiditis, people with vitiligo, people with psoriasis, and people with rheumatoid arthritis. And I suspect the same is true for other autoimmune disorders. Non-classical adrenal hyperplasia is universally encountered in type 2 diabetes, with the exception of people who have no family history of type 2 diabetes and develop type 2 diabetes after hepatitis C virus infection. And those who have type 2 diabetes after hepatitis C virus infection. And Dr. Bhatia has done a good deal of research herself during her training on the relationship between hepatitis C and subsequent type 2 diabetes. About 2/3 of people with type 2 diabetes also have evidence of autoimmunity when highly sensitive tests for cellular autoimmunity are employed. One possible reason for this apparent connection may be that serum cortisol levels in general are lower in CAH patients than they are in the general population. And cortisol and its analogs like prednisone remain an important component of treatment in our anti-autoimmune arsenal. Another reason for this connection between autoimmunity and non-classic adrenal hyperplasia is that the gut biome has alterations such as less diversity of bacterial species. This is common to autoimmune disorders, metabolic syndrome, and phenotypically expressed congenital adrenal hyperplasia, as well as related disorders like gout and polycystic ovarian syndrome. And we describe this relationship between type 2 diabetes and non-classic adrenal hyperplasia in a publication in Diabetes Care in 1995. It's been reported by a number of groups referenced at the bottom of the slide that both non-classical and classical congenital adrenal hyperplasia are associated with insulin resistance. Interestingly, though, none of these groups who've reported this association have explored the possibility of treating non-classic adrenal hyperplasia or classic adrenal hyperplasia by reducing insulin resistance. And one of the points I hope you'll take away from this webinar is that there is an intersectionality between metabolic syndrome, classic and non-classic adrenal hyperplasia, dysbiosis of the gut biome, and possibly other biomes, and autoimmune disorders, and that interventions in one sphere can have beneficial consequences in the other sphere. The more common non-classic form of 3-beta-ol dehydrogenase deficiency is not actually due to an exonic polymorphism as the classic form is, but to an epigenetic decreased expression of the gene. Insulin resistance has been associated in a number of studies, a few of which are listed at the bottom of the slide, with increased risk of developing autoimmune disorders. Insulin resistance and a number of autoimmune disorders are also associated with similar changes in the intestinal microbiome, which include a reduction in diversity of bacterial flora and a reduction in bifidobacteria and butyrate-producing bacteria, which favor insulin sensitivity. Many authors have reported that inflammatory cytokines are involved in the pathogenesis of both autoimmune disorders and insulin resistance. Chief among these is tumor necrosis factor alpha and interleukin-6. Serum vitamin D levels have been reported to be lower in people with disorders associated with insulin resistance, such as type 2 diabetes, polycystic ovarian syndrome, non-classic and classic adrenal hyperplasia, Alzheimer's disease, eclampsia, and preeclampsia. In other autoimmune disorders, polymorphisms of the vitamin D receptor have been associated with susceptibility to that disorder or a more severe clinical course. Supplementation with the active form of vitamin D has been shown to lower the concentration of tumor necrosis factor alpha in a preclinical model of type 2 diabetes. Vitamin D repletion has been associated with amelioration of polycystic ovarian syndrome, non-classic adrenal hyperplasia, and classic adrenal hyperplasia, and as we'll see, with a number of autoimmune disorders. This slide is data from a patient of ours who had the classical form of 11-hydroxylase deficiency. I don't know if Malai is in the webinar audience, but she'll probably remember this patient well. She saw him as a resident during her endocrinology elective. And he had presented not only with type 2 diabetes, but he had hypospadias and he had micropenis. And we evaluated him, as we did most of our patients with diabetes, for adrenal hyperplasia, and he actually had the classical form of 11-hydroxylase deficiency. And as you see in the bar on the left of the screen, he had astronomically high levels of 11-deoxycortisol. We started treatment with ergocalciferol, 50,000 units a week. And by day 9 of treatment, at the middle bar of the graph, you see the level had dropped precipitously. And at day 17 of treatment, the level of 11-deoxycortisol had dropped to the normal reference range. So you see here that an intervention with vitamin D, which increases insulin sensitivity, was able to normalize his abnormal steroid metabolite levels. This shows his data in just a slightly different format. On the left are his 11-deoxycortisol levels declining from baseline to day 17. And at the same time, his vitamin D levels are increasing on the right. This is another patient of ours who had the non-classical form of 11-hydroxylase deficiency. And you see his baseline data on the left was elevated. And several months later, when she returned to clinic, we had found that the level had dropped quite a bit. And about 6 months later, she returned to clinic and her 11-deoxycortisol level was almost normal. And I want to emphasize all of these treatments were in the absence of giving standard treatment, which involves glucocorticoids and in some cases mineralocorticoids. This shows this patient's vitamin D levels increasing over time. And this shows her weight decreasing over time. And weight loss is another insulin sensitizing intervention, which can help to decrease the expression of non-classic adrenal hyperplasia. And this is a summary slide which shows on the left the decrease in body weight over time, the increase in vitamin D at the same time, and the normalization of 11-deoxycortisol. Evidence of vitamin D repletion in prevention and treatment of autoimmune disorders other than vitiligo and psoriasis has been somewhat conflicting. However, as more recent studies where they actually measure the effect of vitamin D supplementation on vitamin D levels, when people achieve a certain level of vitamin D, these treatments seem to be much more effective. In a study in babies, the dose effect of vitamin D supplementation in babies that were over 7 months of age resulted in a significant decrease in the development of type 1 diabetes in those babies who were at high risk because of a sibling with type 1 diabetes or the presence of anti-islet antibodies. Benefit from vitamin D supplementation has been shown in systemic lupus patients on both inflammatory and hemostatic markers and clinical disease activity. Low serum 25-hydroxyvitamin D levels and or vitamin D receptor polymorphisms are associated with increased risk for development of and increased severity of most, if not all, autoimmune disorders. Still, needed are more randomized controlled prospective studies to assess the effects of vitamin D repletion and supplementation on prevention and treatment of autoimmune disorders. An important recent reanalysis of data from the pivotal D2D trial employing a Cox proportional hazards model concluded that daily vitamin D intake sufficient to achieve and maintain a serum 25 hydroxy vitamin D level of at least 100 nanomoles per liter is a promising approach to reduce the risk of type 2 diabetes in adults with prediabetes. And this is in contrast with the original conclusion that vitamin D administration was not effective in the prevention of type 2 diabetes in those with prediabetes. And the difference was really the way the authors looked at the data. In the more recent study, they looked to see that they had actually achieved a certain minimum level of vitamin D in their serum, not simply that they were taking a supplement or were prescribed a supplement. Okay, this is a study we did a number of years ago in our clinic using metformin and, if needed, to optimize glucose control, also troglitazone. Troglitazone is a PPAR gamma receptor agonist. It was the original one when safer ones like pioglitazone and rosiglitazone became available. It was taken off the market. But this is a study of 33 patients who had either type 2 diabetes or prediabetes and also had non-classic adrenal hyperplasia. They ranged in age from 29 to 75. We had 6 men and 27 women in this study. And this just shows you the kind of buffet of clinical features that these patients had. Type 2 diabetes, of course, being very common, central obesity, and acanthosis nigricans. You saw a lot of, but also acne, hirsutism, infertility, alopecia, and an allergic disorder, asthma. And by the way, allergic disorders that we've looked at, for example, eczema, asthma, and allergic rhinitis are also strongly associated with non-classic adrenal hyperplasia. And these show you the steroid biochemical abnormalities and the low sex hormone binding globulins, each bar representing the number of patients that had a particular disorder. And you see we have a variety of forms of non-classic adrenal hyperplasia represented, including 21 hydroxylase deficiency, 3-beta-ol dehydrogenase deficiency, 11 hydroxylase deficiency, and aldosterone synthase deficiency. And this is what happened when we treated these people with 2 insulin sensitizers, metformin alone in some, or if they needed it to achieve good glucose control, also troglitazone. And you can see that all of the abnormally elevated steroid metabolites had normalized with this treatment, as did estrone, and the previously low levels of sex hormone binding globulin increased and normalized. This was a mini study we did of 2 patients with non-classic aldosterone synthase deficiency. One of our former residents, Dr. Osahobo, and I published these first reported cases of the non-classical form. The severe classic congenital form is known as Visser-Koss syndrome. And that's a life-threatening disorder where this is merely a bothersome disorder. So these 2 ladies were, one was 36 years old, one was 41 years old. As you could see, they were a little bit obese with BMI of 32. and an elevation of their baseline deoxycorticosterone at baseline, as well as an elevated LH2-FSH ratio, which is associated both with congenital adrenal hyperplasia and polycystic ovarian syndrome. And this is what happened. They were both very motivated ladies and worked very hard on exercising, diet, and weight loss. And each one achieved about a 10% weight loss, about a 10% reduction in their BMI, and they normalized their deoxycorticosterone levels as well as their LH-FSH ratios. And going along with this, they also noted a normalization of their menstrual cycle, decreased hirsutism, and resolution of acne. And this was another patient. Dr. Bhattiar might remember this patient from our clinic. She had type 2 diabetes and hirsutism. And we treated her for her diabetes with metformin and pioglitazone. And you could see she had a very nice reduction in her 11-deoxycortisol level. Since she was obese, we educated her about the possibility of having bariatric surgery. And she actually elected to have bariatric surgery. And you could see at 5 weeks post-operatively, she had elected to have Roux-en-Y gastric bypass. She returned to clinic. She was off all diabetes medications, off all hypertension medications, off all lipid-lowering medications. And as I had predicted to her, I thought might happen, her 11-deoxycortisol level remained within normal limits without any medication whatsoever, just with the weight loss. And she maintained that for as long as I was still at the hospital until I retired. This was another interesting patient. She was from my private practice. And the first time she came in to see me, she complained of a lot of hair loss. I was a little surprised because I looked at her and she had a very nice full head of hair. But then she took out her phone and she showed me pictures of how her pillow looks when she wakes up in the morning, and her white pillowcase was covered with black hair. So I agreed with her that she did have a problem. So I offered her treatment initially with pioglitazone, and she responded very well. She actually had 2 forms of non-classic adrenal hyperplasia. She had aldosterone synthase deficiency and 3-beta-ol dehydrogenase deficiency. Then, when she returned at her next visit, she said, you know, I'm a little concerned about continuing to take pioglitazone because I've read about it. It can cause bone loss. I'm already seeing a little bit of weight gain. So could I try something else? So I said, sure, we could try some metformin, and I think it'll work nicely for you. So I gave her a prescription for metformin. And when she came back, you see the levels of corticosterone and 17-hydroxypregnenolone that appear on the right side of both graphs. And I congratulated her and I said, look, it looks like the metformin is working just as well for you without the side effects you were concerned about. And she smiled and she said, I have to admit something to you, Doc. She said, I filled the prescription, but I never started taking it because when I came home from the pharmacy, Dr. Oz was on television. For those of you who are not from the United States or Canada, Dr. Oz ran a program about alternative medicine. He was also a very famous thoracic and cardiac surgeon. In his latest incarnation, he is also a Republican Senate candidate from the state of Pennsylvania. But in the meantime, Dr. Oz was recommending ashwagandha, not for the treatment of congenital adrenal hyperplasia by any means, but as a general tonic, energizer, adaptogen that will help you feel more energy, more youthful, more energetic. So she said, I decided to start taking it. And I said, you know, I don't have any familiarity with ashwagandha, but I started to research the literature to see what I could learn about it. And it has a long history in India as part of Ayurvedic medicine, and of about 3,000 years, and about 2,000 years of use in traditional Chinese medicine, mostly again as an adaptogen, general tonic, energizer, aid to convalescent people, and so on. One article, though, from Dr. Ahmad from the University of New Delhi had done a preclinical study of ashwagandha in treating diabetic mice. And the diabetic mice normalized their glucose and their hemoglobin A1C and stopped being diabetic mice. When he did calculations of insulin resistance and insulin secretion, he found that this compound both increased insulin secretion and improved insulin sensitivity. So again, it was another intervention that reduced insulin resistance that seemed to produce these results. It may have had other benefits too that we're unaware of, and other mechanisms of work as well. This is another patient of ours who we were called to see to manage his diabetes. And as you can see, he had very elevated levels of 17-hydroxyprogesterone, 4,000 nanograms per deciliter. He had renal insufficiency, so he wasn't a candidate for metformin, so we treated him with rosiglitazone, a PPAR gamma agonist. And you can see how dramatically his levels of 17-hydroxyprogesterone dropped. And this improvement took place in just 24 hours. There was just one day between these two blood tests for unstimulated 17-hydroxyprogesterone. Okay, this was one of my first patients when I came to Woodhull. I actually inherited this patient from my predecessor, Dr. Mark Joy, who had appropriately diagnosed her with a non-classic 21-hydroxylase deficiency, explaining her complaints of acne, amenorrhea, infertility, and alopecia. And he was treating her exactly textbook perfect with cortisone acetate, the larger dose at bedtime, and with fludrocortisone, a synthetic mineralocorticoid. And you could see that her levels of 17-hydroxyprogesterone in the purple bar were dramatically better, but still very elevated. So at one point, she ran out of her prescription for a few months, wasn't in any life-threatening problems, but, you know, her problems with acne and hirsutism had returned, and her alopecia was worse. And actually, her normal menstrual cycle had never come back. We evaluated her further, and we found she also had elements of polycystic ovarian syndrome. We addressed that with a few trials of clomiphene, which did induce ovulation, but no menstruation. And a hysterosalpingogram then revealed that she had Asherman syndrome, which is a total fibrosis of the endometrial cavity and both fallopian tubes. Most typically, it follows a delay in treatment of a sexually transmitted disease like chlamydia, which is often asymptomatic. So we started to treat her not right away with cortisone and fludrocortisone, but with metformin. And what you can see now with metformin, her 17-hydroxyprogesterone level was lower than it ever was on classical treatment. And then we added also 15 milligrams of pioglitazone, and her 17-hydroxyprogesterone becomes almost undetectable on the far right of your graph. Insulin resistance is also a feature of classic congenital adrenal hyperplasia. And this was a mini study of one patient that I did with Dr. Agdiri, who at the time was our pediatric endocrinologist at Woodhull. This was a 16-year-old young woman who had been diagnosed with classic 21-hydroxylase deficiency. And we don't get to see too many of the classic patients as adult endocrinologists. They tend to stay with their pediatric endocrinologist. And she was again being treated appropriately with cortisone acetate and fludrocortisone. But you could see that both her 17-hydroxyprogesterone and total testosterone are still quite high. And she was having clinical problems. She had developed oligomenorrhea, hirsutism had returned, acne had returned. So we wanted some help. If you read works of a lot of the people noted in the field of non-classic adrenal hyperplasia and classic adrenal hyperplasia, they often caution you against overly ambitious attempts to normalize the 17-hydroxyprogesterone or the testosterone, that can result in overtreatment and features of Cushing's syndrome. So we obtained informed consent, and we added to her regimen metformin, 500 milligrams twice a day. And you can see that this treatment, when she returned to clinic, had more than halved her level of both 17-hydroxyprogesterone and her testosterone. And with it, she had an improvement in her acne. She resumed normal menses, and she was beginning to note some improvement in hirsutism. We offered her to continue the experiment and gradually titrate up the dose of metformin and possibly add pioglitazone and see if maybe we could wean her off of the steroid therapy. She said, "Gentlemen, thanks for what you've done so far. I'm happy with it. I'm just going to stay on this treatment and I don't want to change it." So we didn't get to complete the experiment. So, novel endocrine disruptor effects of classic and atypical antipsychotic agents and divalproax, a induction of adrenal hyperandrogenism reversible with metformin or rosiglitazone. And this was a study conducted in our psychiatric unit at Woodhull, which Dr. Batiar and I published back in 2008. And this shows you the steroid, the numbers of patients in the study with steroid metabolite abnormalities, abnormalities in sex hormone binding globulin, and abnormal LH-FSH ratios. And this is what happened to these folks when we treated them with metformin. The orange bars represent their baseline steroid, sex hormone binding globulin levels, estrone to estradiol ratios, and sex hormone binding globulin, and not sex hormone binding globulin. And the pink or magenta bars show what happened when they were treated with metformin. For sex hormone binding globulin, it's a little confusing. On the right of your graph, the colors are reversed. So the pink or magenta is actually the baseline state, and the orange bar is the post-treatment effect. So what you can see is that all of the abnormally elevated steroid metabolites and ratios decline to normal. The sex hormone binding globulin rose, and the estrone to estradiol ratio also declined. Two of our patients on the psych unit were not able to be prescribed metformin, again, because of renal insufficiency. So we treated them with rosiglitazone, and they also normalized their previously elevated 11-deoxycortisol levels, shown from baseline on the left to post-treatment on the right. While some of the observed benefits of vitamin D repletion and classic congenital adrenal hyperplasia and non-classic adrenal hyperplasia are likely due to a reduction in insulin resistance, the abundance of vitamin D receptors in the adrenal cortex suggests that vitamin D may also have a direct regulatory effect on adrenal steroidogenesis, as Lundquist and colleagues reported. In the case of 21-hydroxylase deficiency, about 9% of affected people have a contiguous gene deletion syndrome involving, of course, the 21-hydroxylase gene, but also the adjacent tenascin XB gene, which is a collagen gene located on chromosome 6. This opens up the possibility that there could be numerous coexistent mutations of 21-hydroxylase and tenascin XB, and those could arise in people having both congenital adrenal hyperplasia and a collagen autoimmune disorder. The fact that these people often have non-rheumatic cardiac valvular abnormalities related to the tenascin XB mutations is consistent with our earlier report in 1997 that people with non-rheumatic valvular abnormalities and non-congenital valvular abnormalities often have non-classic adrenal hyperplasia. Although such valvular abnormalities could also be related to disordered synthesis of a cardiac glycoside called wabane, which the adrenal cortex makes in addition to its steroid hormones. The location of the 25-hydroxylase gene within the HLA locus on chromosome 6, where a host of gene polymorphisms predisposing to autoimmune disorders reside, predicts that 21-hydroxylase deficiency will often coexist with autoimmune disorders. A significant number of patients with partial loss of adrenal function, sometimes called limited adrenocortical reserve, appear well most of the time, but may experience adrenal crisis under supraphysiologic stress, such as from major surgery, infection, burns, and critical illness. Shock and fever may be the only signs. In autoimmune hypoparathyroidism and autoimmune polyglandular syndrome, antibodies against 21-hydroxylase are typically present. Some of these patients may have only a partial form of adrenal insufficiency, biochemically and clinically indistinguishable from people with non-classic adrenal hyperplasia, accompanied by other autoimmune disorders. And if you think about it for a moment, it's not really reasonable to expect that adrenal insufficiency is always going to be all or none, that there are intermediate forms of it as well. And this was an early article from the early 20th century by Dr. Tattersall, who talks about a form frust of Addison's disease. But I would caution, everyone attending this webinar that there's a good deal of careless diagnosis of something that's called, I just lost my place. Let me find it. Oh, here it is. Yeah. Of something called adrenal fatigue syndrome, which is being diagnosed most oftenly without a cortrosine stimulation test. And this was an interesting publication by Dr. Tomczynska from Poland called Metformin, the Drug for Treatment of Autoimmune Diseases, a New Use for a Known Anti-Diabetic Drug, which is a review of a number of articles that had successfully used metformin as adjunctive therapy for treating a variety of autoimmune disorders. Here again, an insulin sensitizer showing a benefit in autoimmune disease. Treatment both with metformin and pioglitazone has beneficial anti-inflammatory effects in patients with multiple sclerosis and metabolic syndrome, of course, and should be further explored. Systemic usage of metformin for psoriasis and cutaneous malignancies has shown promising results, as reported by Dr. Buber and colleagues. A proof of concept trial of metformin add-on treatment of mild or moderate lupus resulted in decreases in clinical flares and the requirements for prednisone, as well as a reduction in body weight, which is another insulin sensitizing intervention. Apart from reducing plasma glucose, insulin resistance as reflected by the homeostasis model assessment, 1IR, and hemoglobin A1C, metformin decreased levels of TSH in both people with spontaneously occurring Hashimoto's thyroiditis and people who had developed autoimmune thyroiditis as a result of interferon exposure. Circulating levels of thyroid hormone, prolactin, that's thyroid hormone other than TSH, and IGF-1 remained at a similar level throughout the study. Interestingly, the beneficial effect of metformin on the serum TSH level was more pronounced in patients with interferon-induced thyroiditis than it was in people who had spontaneously occurring Hashimoto's thyroiditis. And the effect was highly correlated with its impact on improving insulin sensitivity. In addition to their original use, clinical applications for the treatment of specific inflammatory diseases, such as inflammatory bowel disease and rheumatoid arthritis, are expected because many reports indicated the anti-inflammatory effects of PPAR gamma on various preclinical models. In fact, several drugs and compounds are used currently or under clinical trials for the treatment of rheumatoid arthritis, ulcerative colitis, and other inflammation-related diseases. PPAR gamma has been described as being a gene of susceptibility for inflammatory bowel disease, as is the Node2 Card15 gene. Inflammatory bowel diseases are pathologies that are associated with an abnormal immune response in genetically predisposed people to the normal commensal bacteria of the intestinal biome. PPAR gamma, known for its significant role in adipogenesis, is strongly expressed by the epithelial cells of the colonic mucosa, and it is implicated in the regulation of inflammation. Agonists of this nuclear receptor, which exists as a dimer with the retinoic acid receptor, strongly decrease the intensity of inflammation during experimental colitis induced by chemical agents. A deficit of PPAR gamma in patients with ulcerative colitis has been highlighted that could explain their acute inflammation episodes. In addition, bacteria, including those of the commensal flora, are able to regulate, upregulate, and downregulate PPAR gamma expression. Toll-like receptor 4, responsible for the recognition of bacterial motif in the form of lipopolysaccharides, is implicated in the regulation of PPAR gamma and its anti-inflammatory properties. All these arguments make PPAR gamma a very interesting potential therapeutic target for treating inflammatory bowel disease. Pioglitazone appears to have efficacy for the treatment of psoriasis, and it's felt that the clinical significance of its effect and its role in the overall management of psoriasis deserve further study. Addition of pioglitazone to the standard of care treatment for rheumatoid arthritis significantly improves aortic elasticity and decreases inflammation and disease activity with minimal safety issues. Another intervention to improve insulin sensitivity, bariatric surgery, and the accompanying weight loss and changes in the biome, here was employed in treating obese patients with rheumatoid arthritis. They had lower disease activity scores, decreased serum inflammatory markers, and less rheumatoid arthritis-related standard medication use. Weight loss may be an important non-pharmacologic strategy to reduce rheumatoid disease activity. Other factors, such as improved efficacy of the standard medications, the offloading of weight from the affected joints, the improvement of physical activity, which further aids weight loss, as well as providing an additional insulin sensitizing effect and effect on the gut biome, and metabolic changes may also have contributed to these post-surgical improvements. Long-term weight loss in people with psoriasis has long-lasting positive effects on the severity of their psoriasis. Ayurvedic treatments such as ashwagandha that we've referred to before, and a mineral blend called Siddha Makardawa have potential to be used for the treatment of rheumatoid arthritis, as reported in a small study by Dr. Kumar, who cited limitations in the study of small sample size, short duration, non-randomization, and no control group. Curcumin, derived from the root turmeric, ameliorates multiple sclerosis, rheumatoid arthritis, and inflammatory bowel disease, both in humans and animals. It's felt that curcumin may have its beneficial effect in these autoimmune disorders by downregulating key inflammatory cytokines such as interleukin 1 beta, interleukin 6, interleukin 12, TNF alpha, and interferon gamma, and their associated JAK-STAT, AP1, and NF-kappa B signaling pathways in immune cells. Many insulin sensitizing interventions, such as metformin, bariatric surgery, the use of dipeptidyl peptidase 4 inhibitors, and GLP-1 receptor agonists, affect the microbiome and vice versa. Insulin resistance may arise from polymorphisms in the insulin receptor gene, or commonly in the post-receptor insulin signaling cascade. Mitochondrial genetic polymorphisms and gene promoter region polymorphisms are typically missed in most genome-wide association studies. Both acquired and congenital lipodystrophies are associated with insulin resistance, and in fact are also associated with polycystic ovarian syndrome. Insulin resistance, it's important to realize, is generally not global. It involves the PI3K signaling pathway and spares the MAP kinase pathway. So this results in impairment of carbohydrate and lipid metabolism while preserving the growth effects of insulin. We try to compensate by producing more insulin to overcome the resistance, but in the meantime, the MAP kinase pathway becomes overstimulated. Growth may also be accelerated by binding of the excess insulin to IGF-1 receptors, normally important for growth hormone expression. Here, the insulin will mimic the effect of growth hormone by binding as an agonist to the IGF-1 receptor. Insulin resistance is also acquired epigenetically, and we do this every day by eating too much, eating the wrong stuff, and not exercising. And us doctors also prescribe many medications which increase insulin resistance. Epigenetic changes may be due to DNA methylation abnormalities or histone acetylation abnormalities. These can be acquired in an individual's lifetime, yet persist for several generations. They may involve antibodies against the insulin receptor, as in the type B syndrome of severe insulin resistance, polycystic ovarian syndrome, and lupus nephritis. They may also involve changes in the biome, environmental or drug-induced endocrine disruption, and sleep disorders. Continuous light exposure has been reported to induce polycystic ovarian syndrome in a preclinical model. And in a study from Spain, noisy and well-illuminated village festivals have been shown to disrupt reproduction in nearby wildlife. Depending on the site involved, both hypermethylation or hypomethylation and hyperacetylation or hypoacetylation may cause insulin resistance and associated disorders like polycystic ovarian syndrome. There is now ample epidemiologic evidence of important associations between autoimmune disorders, non-classic adrenal hyperplasia, insulin resistance, hypovitaminosis D, and vitamin D receptor polymorphisms. Measures which reduce insulin resistance, including vitamin D repletion, benefit patients with congenital adrenal hyperplasia, as well as many autoimmune disorders, both biochemically and clinically. Vitamin D analogs are useful in the treatment of vitiligo and psoriasis, and supplementation of vitamin D is useful in the prevention of type 1 diabetes in high-risk infants and may decrease the severity of lupus. Vitamin D suppresses many of the inflammatory cytokines involved in the autoimmune process. We are in need of more randomized control trials of vitamin D in the prevention and treatment of most autoimmune disorders. Gene therapy or epigenetic interventions may partially or wholly correct some of the effects of vitamin D receptor polymorphisms. Lessons learned from the recent creation of messenger RNA vaccines for COVID-19 may also be helpful in amelioration of disorders due to gene polymorphisms or due to increased epigenetic gene expression. Manipulation of the various biomes via fecal transplantation, medications, and dietary changes may reverse or ameliorate some autoimmune, metabolic, and reproductive disorders. It is important for us to recognize that exploration of our biome is still in its infancy. Thus far, we've begun to explore the bacterial gut biome and have barely begun exploration of the bacterial, vaginal, and oral biomes. Besides bacteria, the biome contains parasites, protozoa, viruses, fungi, and prions, whose role in disease pathophysiology, prevention, and treatment we can only guess. A group in Mexico has found, for example, that hookworm, a Taenia species, can produce many steroid metabolites, and they have an estrogenizing effect on their host. And we, in fact, have reported a patient in whom widespread Taenia infection was associated with polycystic ovarian syndrome, and using a partial estrogen receptor blocker, we were able to improve her neurocysticercosis and reduce the number of brain lesions that she was affected with. These organisms and pre-organisms actually contain the bulk of our genome, and it's actually humbling to think that more of our genome comes from these little microorganisms than is distinctly human. Gut biome changes in aging, metabolic syndrome, autoimmunity, and cancer. As we age, the percentage of our gut biome composed of bifidobacteria declines to about 5% of what it is when we're young. And with this is an associated drop in insulin sensitivity and many other changes associated with the aging process. Along with this decline in species diversity, there's a decline specifically in beneficial bifidobacteria, butyrate producing bacteria. In general, we see roughly the same changes in insulin resistance or metabolic syndrome and its component disorders like polycystic ovarian syndrome, gout, non-classic adrenal hyperplasia, and the current world epidemic of non-alcoholic fatty liver disease. We also see parallel changes in the gut biome in many cancer patients. Interestingly, there are also, although it hasn't been explored as much, changes reported in other biomes. For example, in polycystic ovarian syndrome, there's actually an increase in bacterial diversity in the vaginal biome. Many drugs and bariatric surgery affect the biome. For example, Akkermansia species are increased by both bariatric surgery and the use of metformin. Bariatric surgery increases gut pH, as do medications like antacids, H2 blockers, and proton pump inhibitors. Aging, metabolic syndrome and its components, autoimmunity, obesity, and cancer are associated with a leaky gut or a decreased gut barrier function, which is an important component of our innate immune system. Strategies to optimize the gut biome include such interventions as fecal transplant from healthy individuals, plant-based diets, prebiotics, and probiotics. While fecal transplant may rapidly optimize the gut biome, sustained dietary changes and sometimes use of specific pre- and probiotics in the long term may be necessary to sustain the beneficial changes accomplished. So what I'd like you to take home from this webinar today is a better appreciation of the association between congenital adrenal hyperplasia, autoimmunity, insulin resistance, and the gut biome. And also appreciate that congenital adrenal hyperplasia can be treated in many people completely or partially with insulin sensitizing interventions, which may improve an individual's overall health as well. I would caution you, though, in patients with the classical forms of congenital adrenal hyperplasia, never to abruptly stop their steroid therapy, because that could be life-threatening, but to taper it gradually and observe the response over time. I want to thank you all for your interest and for tuning in from all the corners of the world. And I'll be happy now to hear your questions and comments. Thank you very much.
Thank you very much for your presentation, Dr. Sacerdote, and sharing your experience, your outcome with patients who have non-classic adrenal hyperplasia. It is time for questions, and I will ask our audience, if you have any questions, please raise hands. We will unmute you or use the chat box, and I will read the questions. And until you think about questions, I have a couple of questions for you, Dr. Sacerdote. The first one is that, how do you explain the relationship between the fact that steroids are counter-regulatory hormones, steroids such as in Cushing's syndrome leads to insulin resistance, hyperglycemia, and diabetes. And in the meantime, the non-classical adrenal hyperplasia has insulin resistance. Could that be due to 17-hydroxyprogesterone level elevation, which was something reported?
Thank you, Gil. That's an excellent question. It turns out that 17-hydroxyprogesterone, as you say, does cause insulin resistance when it's elevated. As far as we know, the mechanism seems to be twofold. One is binding as an agonist to the glucocorticoid receptor. So it magnifies the effect as though actually a glucocorticoid was there on the receptor. And two, it actually increases the synthesis of the glucocorticoid receptor. So you get more glucocorticoid receptors. And that's how one condition where you have an excess of glucocorticoid and another where you have a deficiency can both have insulin resistance. Nevertheless, it doesn't explain why in other forms of adrenal hyperplasia that we've explored, such as 11-hydroxylase deficiency, 3-beta-ol dehydrogenase deficiency, or aldosterone synthase deficiency, we also find that they're insulin resistant. It may be that they're not quite as insulin resistant as those with 21-hydroxylase deficiency, but we don't have that data as yet.
Right, thank you. So another question I have, so could the beneficial effect of metformin in autoimmune diseases are largely mediated by alteration in microbiome and not directly related to the MAP kinase pathway?
I think they're both true. There's a direct insulin sensitizing effect, which you can show even in vitro systems where the mTOR pathway is activated, the mammalian target of rapamycin. But besides that, yes, it has a beneficial effect on the gut flora, as does also bariatric surgery to increase, for example, Akkermansia species, which are associated with better insulin sensitivity.
Okay, very good. So we have one question. This is Tekla. In recent decades, evidence is piling up that supports a lower carb diet to improve insulin sensitivity. Would you still favor plant-based diets?
I think I would still favor plant-based diets with a proviso that they shouldn't be junk food plant-based diets. What you'll find is that a lot of people, when they first adopt a plant-based diet, they'll eat a lot of junk food, highly refined carbs, often with things in them like high fructose corn syrup and things like that. Nevertheless, I think treatment has to be individualized because there are clearly different people who, in terms of glucose control and insulin sensitivity, respond better to these more keto diets or, more high protein, high fat, and others who respond better to the mostly plant-based diets. So I would say I would mostly support a plant-based diet with that proviso that it be, the grains come mostly from whole grains and so on. And
I totally agree with you. There's a difference between being vegetarian and, a plant-based diet person. So vegetarian, as you mentioned, that's, processed foods are available and yet they're not animal products, but pure plant-based is just solely using the plants, legumes and everything. So it's an great impact on insulin resistance. This has been shown.
yeah.
So I'm a big favor of plant-based diet. Very good. Do we have any other questions? Okay. Fen, our fellow Fen, when do add pyroglutamate after metformin? When do add pyroglutamate after patients on metformin? On how many months do you increase the dose of pyroglutamate?
Okay, basically, if I have titrated metformin to the maximally tolerated or allowed by the package insert dose of metformin, which is about 2,000 milligrams per day. If I haven't, first of all, in treating someone with diabetes, you might add pioglitazone if you wanted to go that route. If you're treating adrenal hyperplasia, though, yes, you could add pioglitazone at that point. And you can titrate it at every visit until you have normalized your abnormal metabolite level, say 17-hydroxyprogesterone.
Very good. One question from Dr. Polomi, another fellow of ours. Is there a role of ashwagandha in improving fertility in non-classical adrenal hyperplasia patients, along with improving steroidogenesis as seen in case reports?
Okay, so far, the only report we have is ours, which is a patient with 11-hydroxylase deficiency. She had already had her family, so fertility wasn't a concern. In fact, she was postmenopausal when we saw her. My guess is it would prove beneficial for treating infertility associated with non-classic adrenal hyperplasia, but we just don't have that data yet. And thank you for the question, Polomi.
All right, any other questions? Okay, so thank you very much for sparing time over the weekend, be part of our webinar, hearing Dr. Sacerdote's expertise, seeing all on this site. So again, I have a wonderful weekend and see you sometime on another platform.